The case we are going to do tonight is much more common. You will see it all the time. So this patient had her shoulder anterior dislocate when she was a teenager. Left one, right one, left one, right one. And then those stopped dislocating. And 1.5, 2 years ago, she had an accident where she was on a bicycle and was hit by a car, went up on the car and over. Since then, she has what they described as tendinopathy in the shoulder and very strong shoulder pain. So in the lobby, I did a history that included that. This is Carolyn. Yeah. Have a seat. And it included a physical exam. So for some of you that are not therapists, I'll remind you a little bit about the anatomy. So she has what she describes as a tendinopathy. So partial injury, not tear, in the tendons in the shoulder. But if you had to say what your pain is, 0 is none, 10's the worst.
8.
8. Okay. So one thing about tendinopathy is never an 8 out of 10. So that's the first clue. Yes, she has a tendon injury. She went over a car, she landed, she hit her head, and she has shoulder pain. But when you think about the neck anatomy, you have vertebra, disc, vertebra, disc. Next to the disc is the nerve. This is the shoulder. It is also the C5 nerve root. It is the nerve from between C5 and C6. And this is a fancy medical diagnostic equipment. So when I test sensation, how does that feel? It's okay?
Yeah.
How is that? The same or different?
Different.
More or less? More. So before a nerve becomes numb, it becomes irritable. Mm-hmm. So this is C5, this is C6. Mm-hmm. It's okay? Mm-hmm. And this is okay. So 6 is fine. 5, 4, worse. You see how the nerve is attached to the upper lip? Like that? Okay. So now you know why her shoulder is an 8. That is nerve pain. She also has pain in between her shoulder blades. Some of you who've had orthopedics or physical medicine know that the discs in the neck refer pain in between the shoulder blade. So the pain in between the shoulder says it's a disc in the neck. Pain in the shoulder of an 8 says it's the nerve. The nerve, she didn't have a traction injury, so the nerve says it's a disc. And the MRI, the imaging, says she has a tendon. So now you know she has at least 2, 3 things: tendon, nerve, disc, right? Until you have a tool that lets you treat all those things, the diagnosis is not so obvious. So also, when I went to palpate or feel the disc, you see this lump? That is a goiter. It's the thyroid. It has a word. What's the German? Stoma. That was pretty close. Yeah? Okay. And also because the pain is so strong and because she's had so much trauma to the shoulders, there is a very strong emotional component to nerve pain. So there is the tendon, and that we can repair with one frequency combination for the flat tendon back here. It's the teres. The nerve pain complicates it. So we'll treat one machine will be on the tendon, one machine will be on the nerve, and the other machine will be, this is the other thing under here. Sorry. There is a muscle and a nerve in the axilla, subscapularis, internal rotation, adduction does this. When that nerve comes from C5-6. When the nerve gets inflamed, it gets glued or stuck to the muscle. That adhesion between the nerve and the muscle will restrict motion, and I can treat this tendon until Christmas, and it's not going to recover unless we get rid of the inhibition that's caused by the adhesion in the nerve. So you ready? It's okay. So I'm pressing that hard, like testing a cake. Very light and very painful. So we'll put one machine from here to there to treat the tendon. One machine from here to treat C5 nerve root. One machine for a short time in the axilla to quiet the nerve and get rid of the adhesions. And that machine we will also use to treat the goiter and the brain for the stress and the emotion. So emotions are made from the brain. They don't come from heaven. They come from the brain. And there are frequencies for anger and fear, but also there are frequencies for the brain to quiet the part of the brain that has such strong fear. So because we now have 35 minutes, we'll do 3 things at one time that you would do in perhaps 3 different sessions. Okay? Alrighty, you ready? All right, let's go. Okay, so we're going to put one wrap around the neck. And why do I start with the neck? Because that is where the C5 disc and the C5 nerve start. Okay, so yes, when you have in your clinic, okay, lift and down. So the water conducts the current. So now we have red and green to the one around the neck, and I can clip them down on the piece of the towel that's out of my way. Red and green from one machine, red and green from the other. It's okay? It's okay. There we go. Red and green. So we have 2 machines. And neck to arm. And if you can set your machine on 40 on A and 396 on B, and maybe 200 microamps. So that's for the nerve, 40 and 396, reduce inflammation in the nerve, and make it alternating, and set for 30 minutes. Plus minus, yeah. And this one, 124 on A, and 77 on B. So 77 is connective tissue, and those are the flat tendons, the infraspinatus, the teres major, the teres minor. Oh, that's nice. And then she also has a tear in the supraspinatus, but that's a round tendon, and that will be a different frequency. That's 191. The flat tendons are easier. Supraspinatus will be longer. And then the third machine will go in the armpit. Easy. So you take your hand, nice and careful. It's okay. And you find the subscapularis and black and yellow, also on 40 and 396. So this machine is making the nerve quieter. What's your pain level right now? 6. So it's come from 8 to 7 to 6. That's good. Also, yeah, I'm not sure about the size of the disc. She says the disc is small. I'm not sure I believe it. So we're going to make, okay. Yeah, let's untangle so we're not quite so in the way. So this one will come from the neck to the armpit, to the axilla. It won't take that long because the nerve is short. Longer nerves take longer. The spinal cord takes 1 hour. The sciatic nerve takes 40 minutes. C5 takes 30 minutes. Okay, and this is on 40 and 396 alternating, yeah? Okay. So, what I want you to see, and it's hard because I'm facing away from you, but let me move it, don't you move it, okay? You all right? Right there is where the impingement starts. So the motion is inhibited. See where her hand is? So at just about 90 degrees. Does that make the pain go up? Yeah. And it scares her. So we'll take 40 and 396 and wait. Okay? Stephanie, can you do me how's the pain level? 5, 4, 3, 4. Okay, so the pain has gone down to a 4, from a 8 to a 7 to a 6 to a 4. This is the C5 nerve root. It's short. It will take 10, 15 minutes. It is predictable. The time is fairly consistent. Will you change that to 40 on A and 89 on B? So I promised her that I would use a frequency that would make her less afraid of moving her shoulder, because she told me the patient will tell you what's wrong. She told me there's an emotional component in my shoulder because of the dislocations and how mean they were when they treated her shoulders. So there's a part of her brain that doesn't want anyone to touch the shoulder. So this machine is now treating the nerve, and that will continue to bring the pain down. And before I touch her shoulder, I need to talk to or quiet down the part of the brain that is not just afraid, terrified. Yes? Yeah, terrified. That comes from a part of the brain that keeps you alive if there is a tiger dragging you through the woods. So that part of the brain, we have a frequency. And basically, when you choose this frequency, for me, it's just brain, just because I know. And I've treated so many shoulders. And because she told me. So when this frequency is working, you watch the face when it gets more relaxed. You watch the breathing when it gets easier. And you check the pain. How's the pain level? Okay, pain is still 4. Oh, that's not so bad in the back now, huh? That's okay. Okay. Usually give it 3 or 4 minutes, and that will make just the touch tolerable.
Please explain for the what are you touching there? We cannot see. What are you touching?
Yeah, exactly. So there's one machine from around her neck where that nerve comes. The other machine, yeah, we're on the wrong side, huh? But it's because of the machines, otherwise they would fall off the edge. That from the neck to the arm, which is the C5 nerve root. From the neck to the elbow, which is also the tendon, and right now that's in the back. And now you can go to 396 on that. And then this is from the neck. So there are 3 machines on the neck and this machine in the axilla. So now, when you put your fingers in the axilla, it's not so painful. She expected it to be painful. She winced just in case. But it's not so bad, yeah? Yeah. So you go slow. When someone has nerve pain, it's very tender to touch. And right there, you feel that? Okay. So this lead is in the axilla with my fingers. You're on the armpit, right? If you can go to this one, yeah?
This is the dark.
This one? Okay, whatever this one is, go to 13 on A. So right now it's on 40 and 396. Go to 13 and 396.
Alternating or?
Let's try alternating. I don't trust the disc. If you polarize positive and they have stenosis, there we go. It will make, and it can make an increase in pain. So this is all alternating current. Yeah. Yes, already did that. So while I was talking about it, we ran 40 and 89 to quiet the midbrain. So now my fingers are in the armpit. You feel that's different, yeah? It's softer. Can I move your arm? Is that okay? Okay, we're going to externally rotate a little. And where does that hurt? Up at the top? Yeah, or in the armpit. In the armpit, yeah. Treating this muscle is, I think, against the Geneva Convention. It's possible. It's very tender on everybody. I could take half the people in the audience and you see? And go back to 40 and 396 with that one. So when it gets too painful, you just take the pain in the nerve down and you wait. So this is usually when you find out about their children and their grandchildren and their summer vacation and their garden. And now it's quiet again because it just takes 2 minutes. It's just not that hard. It's short nerve.
Where do you place the pads?
This one is in her axilla. You have to put the fear was just, is there any place in your body that fear is not? You are a semiconductor, right? So she had water, so she is a semiconductor. So it's everywhere. It's a good question, though. You can put it anywhere. I put it on the shoulder just because that's where everything else. Oh, there you go. That's better. And you press find where it's tight, and go to 13. So 40 takes the pain down so you can touch it, and then you wait. Now it's on 13. And you watch the face. What's your pain level? 0 to 10? Where my fingers are, it's a 5. Yeah. So when you do work with your hands, even here in the axilla, there's no need to get above a 4 or 5. It's not necessary. So you wait. Ow. Go back to 40. So with so much trauma in the shoulders, so these adhesions started when she was 13. The first time you dislocate the shoulder, it bleeds. You bruise. Comes out the front, the blood drips down here. This muscle has been scarred down since she was 13, 14. Then you wait. Is that better? Yeah. So it's like I press in the armpit and the axilla, and you can see her eyes looking for it. It's like, okay, right there. And then you go back to 13. So you take the pain down with 40, quiet the inflammation in the nerve, and then scarring in the nerve. It's okay? 13? Yeah. So for those of you that are therapists, how many are therapists? Okay. So to treat the shoulder, you keep your body protected, you pin the shoulder, my fingers are in the axilla, and then you move this way. Slow. The frequencies pulse every 2 seconds. Oh, that's better. And she's looking for the pain. Yeah, it's almost like you don't, yeah, right there, that's icky. And that is actually the long thoracic nerve. That's lower. And go to 40. It's a different nerve. It's also glued. It's down on the chest wall. It's here. 40. And you wait. So in the meantime, her shoulder is supported. She's not using the muscles that are torn. The nerve is being treated. If I'm not pushing, what's your pain level? Gone? 1, 2, 3, 4. So it's okay. And it's where? In the armpit or up here? Up here. So this is impingement. So I'm running into that bursa. My bad. Okay, go to 13 and 396. So stay away from the bursa until I treat it. There you go. It's okay. So you pin the arm, support it, move it. I'm going to avoid flexion because of the bursa. Oh, that's better, huh? Okay. Does it make your fingers fuzzy? A little bit, yeah. So it's making her fingers tingle because I'm on the C5 and 6 nerve root. And this is long thoracic. It's very long. Okay. Sorry. Bad. Axilla. How are we doing for time? Oh, it's okay. So we're 15 minutes into it. Go back to 40 and 396. And if you would, who's on 124 and 77? Is that you? How's this part of the ache? Is that also a 4? Okay. Right in here?
Yeah.
Okay. Try on this machine, go to 40 and 195. So 195 is the bursa. 191 is the round tendon. And the pain she has is right here. It's possibly still the nerve. So you're still on 40 and 396. He just switched to inflammation in the bursa. And the shoulder is very anterior. If you look, she carries it this way. So the pec minor, ow. Yeah. And then the anterior capsule is a little bit scarred. Oh, that's better. So here's something you can do while you're treating. So you reach up with your hand, with this hand, and I want you to feel your shoulder. She is used to her shoulder being very painful when she touches it. So it's a good idea to connect her brain with the shoulder when the pain is a 3 or a 4. Is that better? Yeah. So this is the bursa. So this is how we are going to be able to get more motion. I can't treat the scarring in the nerve down here, this part, until I can move the shoulder up, right? In order to move the shoulder up, I have to not only treat inflammation in the bursa, but probably scarring in the bursa, right? She's had maybe 3 or 4 dislocations on both sides. So that's lots of bruising, lots of bursa. Oh, this is better back here. Yeah? Okay. Oh my gosh. Biceps tendon. Yeah? Is that painful in there? Yeah, no, not bad. That's an improvement. And pain here. Not too bad. Okay, so what I'm doing is palpating the bursas that are at the top of the shoulder, okay? Let's try. When was the last time this shoulder dislocated?
10 years ago.
10 years ago. So there's a pretty good chance that the shoulder is stable. When someone has a lot of instability in the shoulder, you're careful when you take out scar tissue. But I think we'll go to scarring in the bursa on this one, 13 and 195. Because I want to be able, in order to release the adhesions in the nerve down here, I have to be able to move the shoulder, and I can't move the shoulder until we get the bursa to glide. Does that make sense? Okay. I always like it when it makes sense, right? When you see the mechanism. So the bursa is 195. The round tendon is 191. And the flat tendons are connective tissue, they're 77. That's better. Yeah? There's a big bursa in back under the infraspinatus. There's 9 bursa in the shoulder. Isn't that amazing? There's 13 in the knee. That's just a random fact you can bring up at cocktail parties or, social gatherings over a beer. Did you know there's 13 bursa in the knee? Exactly. All right, so now we'll see. What's that one on? 40 or 13? 40, okay. So now let's see if I can keep, oh, there's the microphone. Okay, it's all tangled up in the wires. So now we'll see, what? Stop that. All right. Let me move it. So with the tendon still torn, you don't want her to be moving it actively. Okay? It's okay? All right. So if you go to 13 on 396, it's on 13 and the bursa. Make a little space with just a little traction. Can you see? It's okay. Tell me if anything hurts. It's good. Come on, let go. Sorry. Stubborn. I am more stubborn than it is, though. But the shoulder's okay, right? Okay, so now that you have taken down the inflammation in the bursa and the scarring in the bursa, now it's okay? Now she's nervous. Let's pause. There we go. Let me know if anything hurts and I'll stop, okay? I promise. That's icky. That's just nasty. It's okay? Rest your arm. Can you see? Sorry. You have to go back. This feels like a great big old bruise in this axilla, doesn't it? Feels like it's bruised, right? Okay, so I'm going to let this rest. On that machine, if you can go to 284 and 62. And on this machine, if you can go back to 40, 40, and 195. So let's just keep treating the bursa while we take this bruise out. So 284 is deep old bruise. And it feels like really there is just a piece of... Are you vegetarian? Good. It feels like a piece of cooked meat under here. It's like just a big bruise. So to find out if that's really what it is, you wait. Oh, it gets softer, yeah? And the pain goes down. So when the frequency is correct, it gets softer, the pain goes down. Come on. And go from 62 to 284 and 142, the fascia. So my hand in the axilla is very still. No scrubby circles. That's for Monique. And so you see, it's easy on your body. Now we'll see if we can move it, okay? Oh, jeez. I had my phone on airplane mode. My phone rings into my hearing aids, so it will stop in a minute. It's just annoying. There we go. It's okay. So I don't know if you've ever had a shoulder injury, but I've had several. And the shoulder is very, well, that's better, particular. Easy. It's a huge lever arm, right? Huge lever. There you go. Oh, too much? Pain or fear? Fear, okay. Well, then we'll rest. You just rest. So there's no point in running the frequency for fear. You could, but I'm out of machines. So the shoulder will stop being afraid when it doesn't hurt. All right. I promise I won't drop your arm. Okay? It's okay? So 1, 2, 3 degrees at a time. You move the shoulder very slowly. What do you think? Ow. Now I'm in her armpit again. I only seem like a nice lady. So go back to 40 and 396 for a minute. What's the pain level in your shoulder? Does it actually hurt, or do you think it should hurt? And that's a real thing.
Yeah.
Yeah, you think it should hurt,
No.
but it does hurt.
Tiny, tiny.
So maybe a 2.
One.
A 1. Okay. So how is this possible? It's a 1. It's because the pain was from the nerve. When you can treat nerve pain, getting the pain down is easy. So 40 and 396 to take the pain down. And this is treating the bursa. Now way up there, ow. Is that sore? A little bit. No, I want to treat the periosteum. 40 on A and 783 on B. So we treated the bursa. And when you think, I'm going to move that over there. When you think about the acromion, the tendon, the bursa, right? What are the tissues? Round tendon is 191. Bursa is here. We treated inflammation and the scarring in the bursa. And then what is the bursa scarred down to? The periosteum, yeah. So what would be the next thing you treat? It's the periosteum, 783. First, we treat the periosteum for inflammation. If you think of the covering on the bone like felt, the fabric felt, that is full of little nerves. The periosteum is all nerves. It only looks like bone. It's all nerves. So first, you give the periosteum a little relief, a little love. It's coming. Yes, you get chocolate. In my seminar, I throw candy. Yes, yeah. So now, inflammation in the periosteum. Look at the motion. Easy. It's okay. The muscle is twitching. Is pain or just the cerebellum? So now scarring in the periosteum, and this is still on 40 and 396. Go to 40 on A and 710 on B. So now the nerve was irritated in the neck because of the disc, right? So now that machine can treat the disc. In your office, you would treat the disc at a separate time. The patient can be sitting in a chair or laying on a table, and you treat the disc and the neck while you're answering emails. There's nothing you have to do to treat a disc. That's easy. The nerve is easy. Shoulders are work, but it's different. The biggest thing you learn at the seminar is to go slow, very slow. You let the machine do the work. You paid for that machine. You make it work, not you. It's okay. You ready to go across? A little bit. That's sore there, yeah. Okay. Right there. So the pectoralis is also very tight. Ow. Okay. If you can make that 40 and 94. So her upper trapezius is very tight from the head injury. So when she had the accident, she hit her head, and she has an inner ear injury. Little bit. Oh, there we go. So there's no way to move the shoulder without having the trapezius relaxed. You want to see? Okay. So take your arm out, try not to hit anybody, and bring it up. Okay? Now put it back down. Bring it all the way down again. Yeah? Now bring your shoulders up. Upper trapezius, contract that. Now try and raise your arm. Doesn't work. Yeah, you can't. So in order to get the shoulder, her shoulder, to abduct, we have to relax. There we go. And there's one frequency, the only thing it does. Oh, that's better. Is make the upper trapezius relax. I got it. I promise I won't drop it. Can you lay it back? It's okay. Someone that has anterior dislocations, this is a very scary position. That's okay. You want to go up? You want to try? A little bit at a time. Here, we'll move it in. If I move the ball posterior, she'll be more comfortable. It's okay? All this is passive so far. She's not ready for active yet. Is that all right? Pretty cool, huh? What's your pain level? None? No. Okay. So this is maybe 4 weeks, 8. I tell people twice a week for 4 to 6 weeks. You have done this in how many minutes? Yeah. So it's been not an hour, maybe 45 minutes so far. So my schedule is always 1 hour, but this is difficult, yeah? Velcro. All right. Now go to 124 and 191. Oh, that's nice. Oh, that's better back there, huh? 124 and 77. All right. So, I want to get the pec done. Right there? All right. So the pectoralis major comes from 7. You understand that this is 2 weeks worth of work in an hour, right? Okay. So, what's this one? That's that, right?
40 and 396.
Okay. Can you go to 13 and 396? The pec major, there is C7, C8 nerve root. I don't expect that to be, so this is on scarring in the nerve, and it's right there, right? Yeah, so there's a tender spot right here. And from when I broke my shoulder and we did all the work on it, I know from experience that there is a big artery in between the pec minor and the pec major. So as long as that artery is scarred, shoulder will not roll back. So let's try scarring 13 and the artery 62. So the frequencies are the tool, but your knowledge, there it goes. So this is scarring in the artery, in between. That's so sweet. You feel that? It just melts. Yeah. So you see what your shoulder just did? You see where it is? The shoulder is now rolled back. So scarring in between what? That artery runs in between the pec major and minor, fascia. So you treat scarring in the artery. And maybe that will also help with the cooked meat in the axilla. Ugh. It's a bad image, right? Never mind. With the old bruising in the axilla. Oh, ow, sorry. You only seem like a nice lady. That's better. Oh, nice. Cool, huh? Tender? No. It just melts. So scar tissue just melts. Okay. Oh, that's... Now, are we on scarring in the fascia? 142? On that one?
No, not yet.
Okay, 62. Okay, try 142. I think 62 is better, but we'll see. So the nice thing with the time waiver McMakin system is you can change the frequency. You look over, punch, and it's done. Yeah? Oh, the fascia's okay. All right. Now, the pec, it's hard to see, but now when I lift, it's easier. Yeah? And the pec is grabbing. It's like, wait, 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 don't move this shoulder. So this is the part. So to treat, to let her do active motion, we have to activate the cerebellum. Is that okay? Okay. So now, all right. What's that one? A 94. Okay. Try 40 and 89. So 40 and 89 is back to the part of the brain that's afraid of the shoulder. So quiet that down for a minute because I'm about to ask her to move it. And that would be pretty scary. On this one, what is this one running? 124 and 191? Okay. So let's try active motion. Can you go to 81 and 84? We'll see. Okay. So I want you to try and just lift your arm. Any pain with that? It's okay? So this is the frequency for increasing secretions in the cerebellum. And bring it back. So now, easy. No. You don't let the pec minor grab and relax. So the mechanics in the shoulder are such that the pec minor keeps grabbing. So this is what you would do with exercise to make proper mechanics in the shoulder. So now come out. There. So you contract so that the pec does not grab. That's better. And then bring back. And you want to think about these muscles down here. So you secure, that's it. So the shoulder blade is secure. Now bring it out. And this is increased secretions in the cerebellum. So now a little resistance. And eccentric contraction of the pec major and minor. It's okay, no pain? Okay. And bring it in, nice and soft. Push against my hand, just very light. Do you see how slow everything is? And external, push, push, not too much. This brand new tissue in the shoulder is soft, it's fragile. Okay. It's okay? Okay. Do you want to try and bring it up over your head? You're going to run into a bunch of cables here. Wait, let me get them out of the way. Can you move the cart, Alex? Okay, there you go. I just don't want to pull it off. Okay. She's used to working with horses, so she knows. Oops. No. So her lower trapezius is not securing the shoulder. So in this position, I don't want her upright yet. It's too much work, right? This tendon is too new. So I want you to glue, think of your shoulder blade as going down to your waist. and hold it down with this muscle. There's a muscle down there, I promise. There you go. So you anchor it. Now, there. Now you can see the shoulder stabilized from the top, bottom. Easy, slow. It's okay? Okay, if it hurts, you have to stop. Do you see? So the cerebellum is activating the muscles. This one is keeping the screaming down in her brain. Does it feel scary? A little bit. A little bit. It's okay. It should. There's no reason it shouldn't. Okay. Yeah, I know. Sorry. So let's try external rotation again. That is not so scary as abduction. And let your shoulder roll back. So you see she's not used to using her her posterior stabilizers. So you come forward. Let the shoulder go back. There you go. Up. Yeah. So the muscles that are, any pain? No pain. Okay. The muscles that are new have to be retrained, and the cerebellum will coordinate them. When we get her sitting up, she'll do these movements while seated with just one machine on her. It's okay? Do you see the difference in motion?
When you say muscles that are new, like you're talking about,
The muscles that have been repaired, that had the tendinopathies are better, not all the way gone, but better. 2 more visits, they'll be done. But it's been in pain for 2 years, 1.5 years. Yeah. And then since teenage. All right. And now go to 81 on A and 92 on B. So 92 is the sensory and motor cortex. The cerebellum will coordinate the movement without talking to you about it. Cerebellum will coordinate the movement automatically without your conscious awareness. The sensory and motor cortex is used to this muscle's not working. So now the sensory and motor cortex has to find it and actively move it. So we're going to try the same motion. And this time, it's her brain. It's okay. Take it up. It's okay. And she's moving with more confidence, you see? I don't want too much external rotation, yeah? All right, nice and slow. Now you move it. There you go. So the muscles are weak, and the disc is still needing to be repaired. It's okay? Pain level? No pain. 0. The pain in the shoulder was a little from the tendon, 90% from the nerve. Nerve pain is innate. Now, what we don't know is in 1.5 years, has the disc been repaired, or is the disc still making the nerve inflamed? The disc makes the nerve inflamed. Is the disc healed? Maybe. Sometimes the disc gets injured, it's called phospholipase A2, makes inflammation, that inflames the nerve, and then the nerve hurts. And then sometimes, in 1.5 years, the disc is better. Disc is fine. It's the nerve. So the only way to find that out is in about 3 hours. When you find out, does it come back? But now that she knows, anytime she wants, anytime, she can walk, well, maybe not at 2 o'clock in the morning, but anytime she can walk into his office or her office or your office, and you just run 40 and 396, and she is comfortable, right? Nerve pain is easy. The disc, a little more of a project. The shoulder, I started treating shoulders 22 years ago. So shoulders take training and experience, but that you acquire every time you treat. And it's not so frightening to treat a shoulder when the patient's pain is a 2, as it is to treat a shoulder when the pain is a 7, yeah? So it's much easier. Okay, try again. Push, push, come on, come on. It's okay, it's okay. Push, push, push. Good, and relax, stop. Now come forward. Now when she comes forward, we have, there. Now the pec works, yes? Bring it across, push, come on, come on. That's good, yay. Okay. 970 and 33. So there's a frequency for restoring joy. We're going to do that for a minute. 81 and 142 on one of them. We're almost finished. You're choking? A little bit. We have all these cables. So that's in literally 1 hour, 55 minutes. We started at 11 minutes after 5. Okay, 81 and 142 lays down ground substance. It is increased secretions in the fascia to help repair the tendon some more. And then maybe 49 and 77 with this. So in your office with one machine, you would do each of these maybe in a step for 1 or 2 minutes. And you would have, I just did 4 weeks worth of work in 1 hour. In your office, because you're new at this, it's not going to go so fast. You have 1 hour and the pain goes down. Every time you treat the nerve, then she's happy. Then you can do anything you want with the shoulder. And then you just build your experience over time. And in the seminar, we teach a little bit about how to treat the shoulder and you get some practice. Okay, let's turn it off. Okay, you ready? Come over this way. Yep, now we find out how fragile the disc is. You're going to be lightheaded. Okay. Nice and light. And then right arm. Have her hold that in your hand.
Okay.
Somehow. There we go. All right. So, you ready? All right, here we go. Ready? Thumb up. And watch the wires so they don't pull on her arm, okay? Bring it up. Come up. That's okay. Go on up. Go on up. It's okay. It's okay. Yeah. Amazing, huh? It's not the shoulder. It never was. It was your neck. And this should be on 81 and 84. Yeah? Okay, so he's running 81 and 84. Whoops. Now it's there. Okay. So the little tendon, easy, down. The little tendon is, now it's coordinated. Is the pain down again or is it still up? No. It's okay. All right, so that little tweak says that that tendon, which we treated for 30 minutes, needs another hour. So tomorrow, you have her come in your office when you're eating your lunch, and she sits in a chair, and you run from here to there, and you treat torn and broken in the connective tissue for 30 minutes, torn and broken in the tendon for 30 minutes, and the tendon gets stronger and gets more repaired each time. So now maybe not over behind your head. Try 81 and 92. And just go up to the edge. Don't let it hurt. Go on up. So this is the sensory and motor cortex. That's better. And that's good. And down. Not so bad. Yay. Okay, one more time. So this is the sensory cortex. So now, did you see the difference in the way she moved it? Now her brain knows where it is. Yeah. Okay, one more time. Yeah, you see the difference? This is the sensory and motor cortex. Now the wiring is complete from the brain to the shoulder. Does that make sense? Yeah, can you feel the difference? Yeah. So the cerebellum will coordinate it, then the motor cortex has to find it.
That feels like it's again a part of me.
Yes, it feels like it's part of you. Yeah. So before it wasn't part of you.
Yeah.
So before, when there is so much, okay, rest. So when there is so much nerve pain, the only representation for this arm, this shoulder, is in the pain center in the thalamus. Well, we turned that off with 40 and 89 for 30 minutes. You turn it off. Then you reconnect with the cerebellum and then the sensory and motor cortex. And now there's no pain. Welcome to my world. Okay, and you can turn off. So the other reason to start doing this is it makes practice fun. What could you possibly do that would be more fun than this, right? Yes. Isn't that the best? Yes. Yay.
Thank you very much.
Yeah, you're welcome.